Is the vasospasm of RP restricted to digital vessels? RP predominantly affects acral sites involved in thermoregulation, but studies in patients with secondary RP have implicated vasospasm of the coronary arteries and vasculature supplying additional internal organs as well. Studies in SSC specifically have identified reversible depressions in coronary perfusion and myocardial function in response to cold challenge that are ameliorated with CCB therapy. CCB therapy has also been associated with a 50% reduction in the development of left ventricular dysfunction among a large retrospective cohort of SSC, greater than 7,000 patients, suggesting a possible role for chronic coronary vasospasm as a contributor to cardiac disease. However, additional studies to assess causality are needed. In the evaluation of a patient with RP, what abnormalities may be noted on physical examination? Patients may occasionally present to the clinic with an ongoing attack of RP, thereby allowing a definitive diagnosis. Induction of an attack in the physician's office by submergence of hands in an ice water bath is frequently unsuccessful, seldom necessary, and sometimes dangerous. The physical examination in primary RP is normal. The real goal in patients with RP is to discern the presence or absence of findings attributable to an underlying condition associated with secondary RP. A careful search for evidence of an underlying rheumatologic disease is required. Abnormal peripheral pulses are asymmetric. Involvement may suggest peripheral vascular disease, thromboembolic disease, or thoracic outlet syndrome. Consider performing an Adson's test. Puffy hands, tendon friction, rubs, sclerodactyla, and telangiectasia suggest scleroderma or its variants. NCM is a useful technique in the evaluation of rheumatologic disease and should be performed. Describe the technique, clinical findings, and prognostic value of NCM. Along with the retina, the nailfold represents one of the only sites in the body where direct visualization of the vasculature is possible. NCM involves the placement of a drop of immersion oil or surgical lubricant on the cuticle of one or more digits, usually the ring or middle fingers, and visualization of the capillaries through a magnifying device, an ophthalmoscope set at 40 diopters, dermatoscope, stereomicroscope, or digital video capillaroscopy. The normal nail demonstrates a confluent distribution of fine capillary loops. Dilated, tortuous capillary loops and areas of avascularity, dropout, are often demonstrated in patients with underlying rheumatologic diseases such as SSC, dermatomyositis, and mixed connective tissue disease. Up to 1% of patients initially diagnosed with primary RP will transition to a connective tissue disease, commonly limited SSC, each year. A large prospective cohort study demonstrated that only 2% of patients with a normal NCM and negative SSC antibodies, SCL70, CENP, RNA pol3 or Th2 developed subsequent SSC. In contrast, 80% of those with an abnormal NCM, vessel dropout and dilation, and a positive SSC antibody went on to develop SSC. The presence of either an abnormal NCM or SSC antibody was associated with progression to SSC in 30% of patients. NCM was more strongly associated with progression to SSC than antibody presence. List the red flags that would be worrisome for the potential presence or later development of a disease associated with secondary RP. 1. Onset of digital vasospasm after the age of 40 years. 2. Male sex. 3. Asymmetric attacks. 4. Trophic changes in the digits, ulcers, pits, gangrene. 5. Ischemic signs, symptoms proximal to fingers or toes. 6. Worsening symptoms despite warm environment. 7. Abnormal NCM. 8. Sclerodactyla, rashes, or other obvious evidence of an underlying condition. 9. Serologic presence of autoantibodies, especially anticentromer antibodies or antibodies against a specific nuclear antigen, SCL70, Th2, RNP, SM, SSA, SSB. Which laboratory studies are worthwhile in the evaluation of a patient with RP? In cases of suspected primary RP, typical age of onset, normal examination and NCM, lack of red flags, laboratory studies are typically unnecessary. In primary RP, laboratory tests will often be normal or negative, although up to 1/3 of patients will exhibit low titer of anti-nuclear antibodies in their serum. Less than 25% of these patients develop an autoimmune disorder unless they have a nucleolar or centromere pattern. In patients with clinical evidence suggestive of a secondary cause of RP, appropriate studies for the presence of a hypercoagulable state, cryoglobulins, hypothyroidism, and SSC-specific antibodies should be considered. Describe the usefulness of vascular or other studies in the diagnosis of RP. Patients with primary RP rarely, if ever, require non-invasive or invasive vascular studies. In patients with SSC or other secondary causes of RP, vascular studies may be helpful in a subset of patients to clarify the extent and severity of vessel involvement. Clinical scenarios in which vascular studies may be helpful include asymmetric finger or hand involvement, high clinical suspicion of secondary causes of RP such as thromboembolism or Buerger's disease, an abnormal Allen's test suggestive of proximal artery disease, or severe disease resistant to initial vasodilator therapy. Non-invasive studies include brachial finger index measurement, gradients over 20 mm Hg suggest a proximal fixed obstruction, Doppler ultrasound studies, and finger photoplethysmography, which can generate pulse volume recordings. Significant vascular disease in SSC is typically confined to the level of the palmar arch and digital arteries, vascular pruning, but more proximal involvement can occur and may be suggested by an abnormal Allen's test and confirmed with vascular studies. See question 20. Invasive angiography or magnetic resonance angiography may reveal an embolic source or proximal vessel disease such as with vascular thoracic outlet syndrome (VTOS), but these studies are often unnecessary in the initial evaluation of secondary RP. In patients with suspected VTOS, chest radiography may demonstrate a cervical rib as well. Which general measures are important in the treatment of patients with RP? The majority of RP patients respond best to simple prevention measures. Careful planning of one's activities. of daily living minimizes unnecessary exposure to cold. Because reductions in core temperature as well as peripheral temperature may induce digital vasospasm, it is important to promote total body heat conservation. Layered clothing, warm socks, hats, and scarves should be worn in addition to gloves or mittens. Tobacco, sympathomimetic drugs, decongestants, amphetamines, diet pills, and beta blockers must be avoided. Biofeedback training may be effective in some patients with primary RP. When is pharmacologic intervention indicated in the management of RP? Most patients with primary RP will not require pharmacologic therapy. Those with secondary RP more often require, but less often respond to, medication. Therapy for secondary RP should address the underlying disorder and vasospasm. Pharmacologic intervention is indicated in patients who suffer from frequent, prolonged, or severe episodes of RP in the setting of adequate preventative measures or with minimal provocation. Patients who manifest evidence of ischemic injury, digital pitting, etc., should also be counseled on medical management. Many patients who require medication may only need it during the colder months of the year. Beta blockers and smoking should be discontinued. Any evidence of digital infection should be treated with antibiotics. Analgesics may be necessary to reduce pain, which can contribute to vasospasm.